There is a natural negative pressure gradient within the thoracic cavity that helps maintain homeostasis. It's what makes it easy for us to inhale and exhale, and it's what keeps our lungs expanded. There are natural and normal causes or illnesses that can impair this negative pressure gradient, such as pneumonia, pleural effusions when fluid collects in the pleural space, as well as a pneumothorax or any kind of traumatic injury to the thoracic cavity. These obviously will impair gas exchange. It's going to make people have a hard time breathing, and they may require supplemental oxygen. A lot of times there are ways that the body can repair itself in the case of pneumonia or with smaller pleural effusions, but there are cases where we have to use external sources to impair this natural negative gradient. The easiest way to think of this is if you've ever heard of a sucking chest wound. Whenever you have a traumatic injury, you hear that sucking, and that is a vacuum being created because you've impaled the chest wall and disrupted that gradient. So that is when chest tubes come into handy. Basically, at its most basic, a chest tube is a tube that's inserted from the outside of the chest wall into the pleural space, and it helps to drain any air, blood, or fluid that is causing the lung to collapse in on itself, and it allows the body to heal itself. We can do this the way it's done. We recreate this negative environment through this atrium by hooking it up to suction and helping facilitate the drainage of these things. Just to make sure the air, blood, or fluid is not flowing back into the pleural space and the body can heal itself. This creates a one-way valve system. That way everything's flowing out and it's not flowing back in, or a water seal. We can also add suction to facilitate this drainage, but we have to use this cautiously, and we have to be mindful of the amount of suction that we use because it can cause trauma or an internal hematoma. Alrighty, the first thing that we're going to look at when we're performing a physical assessment or on our patients with a chest tube is we're going to walk in the room and make sure that the chest tube is sitting upright and it is below chest level with the tubes and everything draining. We want this to be typically on the floor, so anything that's draining out into the tubes, it's not flowing back into the patient, which is typically why we use suction. We're going to always check our orders at bedside report and see if the doctor wants the chest tube to be on suction or not. This guy right here is the suction port. It's on the top left portion of the atrium. This is where it's going to, the suction tubing is going to be hooked up to. You do not need to have, since this is wet suction technically, it goes through the atrium. It can just be hooked up directly to the wall. It doesn't have to be through anything else. And this guy right here, also on the top left, you can see this is how we are determining the degree of suction that the patient is receiving. So you can see it is on 15 right now. If the patient is on suction, we're going to look at this canister right here. I'm going to turn it to the side. You can see a little orange balloon in there. If a patient is to be on suction, this balloon should be fully extended, and that's how we know that the patient is getting the degree of suction that they're prescribed. Next thing we're going to do, as well as our focused respiratory assessment, is we're going to look at this chamber right here. This is how we're going to assess for an air leak. An air leak is not necessarily bad. You have to kind of correlate it clinically with your patient. If a patient has a pneumothorax that's air, you're going to see air leak because air is being taken from the chest. However, we want to see this getting better, and it should never be continuous. There's a little ball right here. You'll see the ball bounce up and down with each breath the patient takes, and you'll see bubbling in this chamber if the patient has an air leak. You'll see it's numbered 1 through 4. And this, depending on how high it is, 1 being the lowest and 4 obviously being the most severe, this will determine the severity of the air leak. So I would say probably a +1 or a +2 intermittent air leak with breaks can be considered normal, but of course you're always going to document and notify your provider with any new findings. The next thing we're going to do is assess the tubing of the chest tube. This portion of the chest tube will ideally be hooked up to your patient. If you walk in and find this detached from your patient, we've got other problems. But we're going to perform what's called a tip tilt test. And whatever drainage is collected in the tubing, you're going to just pick it up and tilt it into the drainage canister. Alrighty. We're obviously also going to be assessing the drainage that's coming from the patient and dumping it into the canister. We're going to look at the drainage in the canister. This will be a collection of everything that the patient's chest tube has put out since it was inserted. We're going to look and make sure that as the canister fills up, we're obviously seeing the darkest drainage or the most purulent or whatever is going on with the patient at the beginning. And we want to make sure that the drainage is getting lighter and the patient is producing less of it each assessment. If not, you want to make sure you're notifying the provider. Last thing we're going to do is look at this chamber right here, B. This is where we're going to assess for tidling. There's water in this canister, and if a patient is not connected to suction, you will see rise and fall with this little ball right here as the patient is taking deep breaths, inhaling and exhaling. If you do not see tidling in a patient who's to water seal, it can mean a couple things. One, your chest tube system isn't functioning, or two, the patient's leak has been fixed and they probably can have their chest tube removed. So it's just another one of those things you have to correlate clinically with your patient. And if it's new, you're obviously always going to notify that to your provider and switch out your chest tube atrium just to make sure everything's working. So what happens with a chest tube if it becomes dislodged? Well, there are a couple things you always need to keep at bedside. One is a canister of sterile saline or sterile water. And then just dressing supplies. So I just have Metapore tape and some 4x4s here. Depending on where the chest tube becomes dislodged is going to determine your interventions. So you can see right here, this is kind of where a chest tube can become dislodged. So if the chest tube is still in the patient physically and it becomes dislodged at the atrium, like let's say it becomes dislodged from this area, and this gets knocked over and you can't use it anymore. What we're going to do is we're going to open our sterile saline canister and we're just going to go ahead and put this guy in here. This is essentially going to create a one-way valve system similar to the atrium. Obviously, it's a little less complicated, but it gets the job done. It's going to allow drainage and everything to drain into the saline and water, or excuse me, and air, without allowing it to backflow, and it's keeping the end of the chest tube clean. So this buys us a little bit of time until we can get a new atrium. Now, what if you're walking your patient into the bathroom and it becomes actually dislodged from the patient? Well, we kind of talked about that negative pressure gradient and how it's super important. So we've got our sterile dressing change supplies at the bedside as well. The first thing we're going to do, I always tell everyone just to put on a pair of clean gloves, put your hand over the site and call for help if you don't have anything. If you do have gauze sponges or 4x4s, everything at the bedside, all you're going to do is open up your 4x4 sponges. You're going to place them over the chest tube insertion site, and you're going to get 3 pieces of tape, and you're going to make a 3-sided dressing change, or excuse me, a 3-sided dressing. The reason we only do 3 sides is because we want to allow air to escape that wound if need be. So it's not creating a tension pneumothorax or making it worse. And then obviously you're going to call for help or initiate a rapid response or code blue if the patient experiences respiratory distress. But that's the basics of chest tubes basically.